Hello, everyone, and welcome to How Genetic Testing for Hereditary Cancer Susceptibility Impacts Patients and Their Family. We are glad you could join us. My name is Elaine Gonzalez. I'm the Community Educator at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. The Breast Cancer Resource Center, BCRC, is a community-based nonprofit serving Central Texans impacted by breast cancer since 1995. Strengthened by our mission to empower those affected by breast cancer with personalized support and compassion, and in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers individualized patient-centered care for diagnosis through treatment and into survivorship. Through its two pillars of support, guidance and education, BCRC certified patient navigators, whom all are breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable participants in their healthcare journey. This program is provided as part of a cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of supportive services for young breast cancer survivors and young women with metastatic breast cancer and their caregivers and families. This CDC funding continues today. I would like to introduce our first speaker. We are so honored to have with us today Angela Trepanier, licensed genetic counselor from Wayne State University.
Hi, everyone. I'm really happy to be here. I am a genetic counselor from Michigan, and I have worked with the Centers for Disease Control and Prevention on a cooperative agreement through the Michigan Department of Health and Human Services for about 10 years. Our goal being to improve appropriate access to cancer genetic counseling and testing in the state of Michigan. And so this is a subject very near and dear to my heart, and I'm really happy to see all of you here today so that I can talk to you about ways to navigate your patients to cancer genetic services. And the goals of what I'm going to talk about today are to help you recognize how a person's family history and personal medical history can be used to see if they are at risk for having hereditary breast cancer, explain why it's important to identify people at risk, help you determine how to navigate those at risk to cancer genetic services, and help you address some of your patients' common questions, concerns, and misconceptions about genetic counseling and possible genetic testing. But just to give you a little bit of background about cancer genetics, I don't know how much genetics people have had. Some people probably had a lot, and some people might not have thought about genetics very much since high school. But just when it comes to cancer, we know that all cancers are genetic because all cancers develop due to changes in the genes that we normally have that have a function in allowing our cells to grow and divide and replace themselves normally in a controlled manner. And if those genes go awry, that's when cancer develops. So changes in those genes are what cause cancer to develop. So even though all cancers do occur due to changes in our genes, most of the time cancer is not inherited. Most of the time these changes in the genes all happen by chance after someone is born over the course of their lifetime. And this little graphic here just shows you that it requires changes in multiple genes for a cell to go from a normal cell to a cancer cell. So what proportion of breast cancer is hereditary? I already told you that all cancers are genetic, but what proportion really are hereditary, meaning that they're running in families because there's a change in one individual gene that's being passed on throughout the family. And with breast cancer, it's about 5 to 10%. With other cancers like ovarian, for instance, it might be as high as 30%. So it does vary from cancer to cancer, but it's about 5 to 10% for breast cancer. And then there's two other classifications of cancer in families. There's familial, and then sporadic is the biggest chunk. And we're going to talk about what that looks like when it comes to looking at family histories. And this is an example of a sporadic family history. And just to orient you, as genetic counselors, we are always taking family histories using these squares and circles. Squares are people who identify as male. Circles are people who identify as female. And these individuals across are the ones that are all straight across in a line are siblings. When a line drops down, it's a child. A line above is a parent. And so we draw these family histories to look at patterns in the family to help us assess whether or not a family history looks hereditary. And in a sporadic case, which is the most common chunk of that pie, what we tend to see is that in a family, there's maybe one person with breast cancer. They were diagnosed at an average age of onset. So usually that's, in the late 50s, early 60s or later. That person had a single breast cancer, so not bilateral breast cancer. And there's no other significant history of breast cancer in the family. And when we see something like this, we suspect that it's probably sporadic. It happened by chance. And in this case, other people in the family typically are not at increased risk of developing breast cancer. And so screening for other family members would be just your typical population screening, usually, unless there's other risk factors outside of family history. And right now, in these cases, genetic testing would not be recommended. But then when I see a family history that looks like this, where in this case, we have 4 people who have developed breast cancer in this family history. So we have this individual here, their mother, their daughter, and also one of their nieces through a brother. All were diagnosed with breast cancer or a related cancer. And the one thing that you can see in this family history is that it's in all generations, it's in all 3 generations. And you can also see that the cancers occurred at an earlier age of onset than usual. And for breast cancer, anything younger than 50 is considered early age of onset. And so whenever we see a pattern like this, or if we see other factors, like an individual who had 2 or more separate cancers, so breast cancer that developed in both breasts, or breast cancer and another cancer that can be related to an inherited syndrome like breast and ovarian cancer, or if we see this family history and certain tumor characteristics, or just those tumor characteristics on their own, like triple negative breast cancer, then those things start to alert us that there could be an inherited reason for the cancer running in the family. And in these cases, we suspect that there's an inherited change, so one that's passed on through the family in a single gene, and the inheritance is usually autosomal dominant for most breast cancer genes. And these are just some examples of hereditary breast cancer syndromes and the genes that cause them. There's a lot more, but just to put it in perspective, there are several genes that can increase a person's risk of developing breast cancer. The most common are BRCA1 and BRCA2 that cause hereditary breast cancer, ovarian cancer. They are associated with an increased risk of male breast cancer, prostate cancer, pancreatic cancer, and melanoma. But you can see there are other ones as too. There's a condition called leukemia that has other cancers like sarcomas and lung cancers and leukemias. There's a gene called PTEN that's associated with thyroid and endometrial cancers with that breast cancer and some other things. And then there's a CDH1 gene that causes hereditary diffuse gastric cancer, so a particular type of stomach cancer and breast cancer. And this is just a subset, but just to give you a sense that when we're talking about hereditary breast cancer, we're talking about a lot of different conditions, not just one. And depending on which gene is involved in any given family, the management in that family for looking for cancer, screening, and possible prevention is going to be different. And that's one of the reasons it can be really helpful to identify hereditary cancer in a family, because it can help you identify not only that there's an inherited risk, but what the risk is for. And autosomal dominant means that we all have 2 copies of every gene. And if the condition is dominant, only 1 copy of that gene pair needs to have a mutation, so a change in the gene that prevents it from working, in order for that person to be at increased risk of developing certain types of cancers. And when a mutation is identified in the family, ideally we want to try to identify it in a person that's had cancer already. That's the best way to get what we call an informative result, but it doesn't always work out that way. But when we do identify a change in the family, a mutation in the family, then we can offer testing to other family members to see if they carry that change. And if they carry that change, then we know that they have an increased risk of cancer. And if they don't carry the change, then that typically means that they have just the general population risk of developing cancer. But the other important thing that I want to point out is that even when a person does have a change in one of these breast cancer genes, most of the time their chance of developing breast or other cancers is not 100%. And that's something called reduced penetrance, which just means that not everybody develops cancer when they have a change in these genes. And that's because, like that first diagram I showed you, it takes changes in multiple genes for a cell to go from a normal cell to a cancerous cell. And then cascade testing is what I just described, is when a person has identified a mutation in their family, and then other family members can choose to have testing for that mutation. And in genetic testing, when there's a mutation in the family, usually it's the person that has that mutation that is responsible for sharing the information with relatives. Part of that is just related to the privacy regulations that we have related to healthcare in the US. And it can be difficult, as you can imagine, to be the one to have to share that information. When, as a genetic counselor, we try to work with families to help them disseminate this information to their relatives by writing family letters, providing guidance on how to do that. And then there's also some support resources for cascade testing. And when you get the slides, you can click on these links to find what some of those resources are. But cascades testing is really important because it can save lives in a family. Knowing that somebody's at increased risk, again, is going to change how they're managed medically, and that can help reduce their risk of developing cancer, or it can identify cancer at an earlier, more treatable stage. And why would a person want to know? Like I said, it's because medical care is different in those hereditary cases than in sporadic ones. And depending on the gene involved, that what type of screening they're going to get is going to vary. But just as an example, usually with breast cancer screening in an inherited family, instead of just having mammograms, oftentimes both breast mammograms and MRIs are offered. Depending on the condition, screening for other cancers might be part of the follow-up. And then there might be preventative or other risk-reducing steps available. And so we want to make sure that families are aware of that and can take advantage of having that additional screening or prevention. So again, the goal is to reduce their chance of developing cancer or to identify it at an early, more treatable stage. And then I just wanted to round out this part of the talk by saying that not all families fall into the either hereditary or the sporadic category. There's this middle category called familial cancer, where there's more cancer than we expect based on chance alone, but usually without those features of early age of onset or people with multiple cancers in one individual, and no clear inheritance pattern. And many of these cases may be due to something we call multifactorial influences. So a combination of genes and environment together, lots of genes, each with a small effect, and some environmental factors that cause there to be more cancer in a family than you would expect based on chance. In these families, we have some risk assessment tools we can use to try to, in some types of cancer, to try to identify, what degree of risk does this person have, and that can help drive what sort of medical management is offered, whether it's typical population screening or something a little bit different. So taking a family history in these cases is still important because it can still drive changes in medical management, but many times genetic testing is less valuable in these sorts of families. It's not absolute, and sometimes testing is done, but you're less likely to find a change in one of those hereditary cancer genes in families like this. And there is a type of testing that's is starting to be offered. It's called polygenic risk score testing. That testing is still sort of being evaluated to determine if it really is, when it says that somebody is at increased risk, if it really works. So it's kind of in progress, but that might become available more readily in the future if we do have evidence that it helps identify these moderate risk families who might benefit from additional screening. And the key points I want to make is that all cancers are genetic, but not very many, just about 5 to 10% are inherited, but that's still an important part to know about. Risk factors include early age of onset, having 2 or more cancers, having multiple affected family members, usually in multiple generations, and then certain tumor characteristics. And then people at risk of hereditary cancer might benefit from additional screening and preventative measures, and that's why we want to identify people with hereditary cancer. And testing relatives once a gene has been identified in a family is a really important way for their health care to be managed appropriately. Now, what do you do when you think that you might have a patient at risk? Well, the first thing that you have to do is try to figure out who's at risk. And in genetics, we do that by taking a family history, but there are other ways that you can identify that information as well. But one of the things that you want to be able to do early on when you're trying to assess risk is know what questions to ask about the family history, just to see if you can identify any red flags that this cancer could be, or that the family history could be hereditary. And, in genetic counseling, we have a lot of time to take family histories. In your clinics, you may not, but if you just ask people questions about the cancers in their family, and mainly what organ did the tumor develop in, or what part of the body did it develop it in, what age were they diagnosed, looking for early age of onset, and how many different tumors they had, trying to distinguish between recurring cancers versus the new primary tumors, which is what we're looking for. Just asking those questions about your patient and close relatives can sometimes give you the information you need to know whether further investigation is warranted. And why would you take a family history? It can help you and the patient recognize patterns of cancer in the family. It can help you understand your patient's experience with cancer and how they're feeling about that. It can help you identify your patient's motivations or concerns about cancer risk, and it can help you identify family dynamics. And if you prepare the patient in advance, it really can help, because it can help you explain, it helps if you explain what you're doing and why you're doing it, why you're asking for this information. It helps if you explain to them what type of information you are looking for, especially in advance, so that they can ask their family members if they're in contact. And it can help ask patients what questions or concerns they may have before you even get started. So if you can learn that up front, it can help you know how you need to share information with them and how ready or not ready they might be for having this conversation. And there are tools online where you can actually have the patient collect their own family history information if they have access to the internet. And this is just one of them. And then there's also risk assessment tools that you can use, where you can just ask a few questions and put them into these tools to assess risk. And I've put links here. And then once you've collected some sort of information, then you want to assess risk by looking for those red flags that I mentioned before. And sometimes, like I said, I know that you don't all have time to take long family histories, but sometimes you can just get a little bit of information. For instance, like if you find out that somebody in the family, a first or second degree relative, has been diagnosed with ovarian cancer at any age, that by itself is enough to warrant genetic counseling and testing for hereditary cancers. And I've listed a few other of those like key features that by themselves can indicate a need for genetic counseling and testing. And trying to identify families as rapidly as possible when you're busy is really important, I know. And so these are just some of the cues that you can use without taking a full family history that can help with that. And what if you do identify a need for a referral? Then the next step is to find a genetic counselor, prepare the patient, and prepare yourself. And here are some resources for finding a genetic counselor. I have one specific to Texas, but also there's a National Society of Genetic Counselors, and there's a couple of other places where you can find genetic counselors, medical geneticists who are physicians trained in genetics, and then genetics clinics. And then again, preparing your patient, because people have often not heard of genetic counseling and don't, sometimes people say to me, I don't need counseling. And genetic counseling is more about providing genetic risk information while supporting patients, knowing that sometimes the genetic risks they have in their family have been difficult for them and their family members. But here are some links to information that you can provide to patients about what genetic counseling is and what they can expect. And then Force, we have somebody from Force here today, but this is a great resource. And there are resources in Spanish that on the Force website that talk about all aspects of genetic counseling, genetic testing, and risk management, risk assessment and risk management. And then also the CDC has a wonderful Bring Your Brave campaign that has actual testimonials from people who have had genetic counseling and testing to put it in perspective for people and see what the experience is like. And then last, you want to prepare yourself. What does the genetic counselor need from you? Usually we'd like to know whatever information you collected up front about the potential risk in the family. If your patient has testing, will you get the test results? How long does it take? And then how can you best work with the genetic counselor to provide the best care for your patient? And then here is a website with resources. This is from the Michigan Department of Health and Human Services. These are some of the resources we've developed over the years, including 4 steps to making appropriate referrals for cancer genetic risk assessment and counseling, a guide to hereditary cancer indications, and you can see all the other ones here. So to summarize, all cancers are genetic, but just a small percentage are inherited. But it is important to identify those people with an inherited risk because it can help either identify cancers in them at an earlier, more treatable stage, or it can prevent cancer from developing. And identifying patients at risk involves collecting some degree of family history information and identifying red flags. And there's lots of tools and guidelines available. And most importantly, providers like you are the key to helping individuals at risk get access. We know that only a fraction of people who are at risk for hereditary cancer are actually identified. And we know that that's even more true in people who come from underrepresented backgrounds. So you can really help improve access. And so I'm going to stop sharing. And thank you for your time.
I want to next introduce our next speaker. We're so honored to have with us today Lisa Slager. Hi, Lisa. Lisa is the Vice President of Public Policy from Force Facing Our Risk of Cancer Empowered. Thank you, Lisa, for joining us today, and I'm going to turn it over to you.
Thanks, Elaine. I appreciate the introduction, and I'm very happy to be here today. As she shared, I'm Lisa Slager, the Vice President of Public Policy for Force. Let me just pull up my slides here. Okay. So I'm going to talk today about insurance coverage and reimbursement for not only genetic counseling and testing, but also the downstream services that an individual might need if they in fact test positive for an inherited genetic mutation that causes increased cancer risk. So as Angela shared with you, there are a number of different genetic mutations that we test for these days. Most of you have probably heard of BRCA1 and BRCA2, but there are many, many others, including 5 mutations associated with Lynch syndrome that can cause up to 50% risk of colorectal cancer, and then other mutations such as ATM, PALB2, several others that are also associated with increased risk of breast cancer, which is really our focus today. This chart just gives you a sense of the different mutations that could be associated or could be causing a hereditary cancer in an individual and their family. So as you can see, there are many mutations associated with breast cancer in women, as well as numerous other mutations that cause other types of cancer. So it's important that we look at not just patterns of breast cancer, but several other types of cancer that can be associated when we're looking at who should be referred for genetic counseling and testing. So let's start at the beginning and figure out what is covered currently or what's required to be covered under regular insurance, which is what most of our community has, either through their employer or through the Affordable Care Act market exchange. So under the Affordable Care Act, anything receiving a grade A or B from the U.S. Preventive Services Task Force is supposed to be covered with no out-of-pocket cost. So things like mammograms starting at the age of 40, if that is in fact a guideline from the task force, that would be covered with no out-of-pocket cost for the patient. Similarly, colonoscopy starting at age 45, once every 10 years, should be covered with no out-of-pocket cost to the patient. If something is given a grade C, that means that it doesn't have to be covered at 100%, and it's really up to the insurer whether or not they want to cover that service. So a good example of that is prostate cancer screening. The task force determined that the evidence supporting that screening is mixed, so they gave it a grade C. So ultimately, that means that insurance companies can decide if they want to cover it or not, and they can charge the patient some out-of-pocket cost for that service. So let's keep that in mind as we go through the coverage for genetic counseling and testing, as well as the associated health services. So as far as genetic testing goes, coverage of specific screening and preventive services are supposed to be available with no copay or deductible to the patient. And one of those services is genetic counseling and BRCA testing, so BRCA 1 or 2 testing, specifically for women with a personal or family history of cancer that looks suspicious for hereditary cancer. So the task force decided when these guidelines were established that it was only beneficial for women to have this service. We believe that's very short-sighted. That doesn't align with other medical guidelines, but that is the current guideline. It also specifically zeroed in on BRCA genetic testing. So that is not the standard of care these days for the most part. Generally, we're doing multi-gene panel testing. Regardless, if an individual is referred for genetic counseling and testing, that counseling as well as testing should be covered with no out-of-pocket cost if it's a woman and if they are just looking at the BRCA mutations. Given that that is not the current standard, most people who are referred for genetic counseling and testing do undergo additional screening with more comprehensive testing, but they still incur a relatively small out-of-pocket cost for testing, and we'll get to that. So because of the U.S. Preventive Services Task Force, there are certain gaps that do exist. The task force was really focused on prevention. So currently, cancer survivors in treatment, as well as men, testing for other genes, or if an individual previously tested negative, but we've come out with new discoveries, it may not provide for coverage of those services at 100%. It doesn't mean that the insurance company won't cover it. It just means that it may not be covered at 100%. So the patient might have some out-of-pocket costs depending on their insurance. So generally, as we shared, most people have private health plans through their employer or through the exchange, unless they are of Medicare age. And the majority do cover genetic testing. In fact, all cover genetic testing for women who are unaffected, meaning they don't have cancer, and that should be covered at 100%. But beyond that, most insurers cover much more comprehensive genetic testing for Lynch syndrome and for multi-gene panel testing with a relatively small out-of-pocket cost. Historically, there was some resistance to testing men, but as we have developed more evidence that men are at significantly increased risk of things like metastatic prostate cancer, colorectal cancer, male breast cancer, most insurers are very happy to test men for these mutations as well as women. Forgive me for using gender-specific terms, but that's the way most of these policies are written. So, I'm just trying to explain this in the terms of the policies that exist. As I said, most do cover it. They might, charge the patient a small out-of-pocket cost, but there's definitely widespread availability of this access to testing. I will note that some insurers require genetic counseling prior to testing. So for instance, Cigna was one of these companies. So if you try to refer a patient without seeing a genetic counselor or having them have some sort of counseling, it could be denied initially until that individual is able to see a genetic counselor. So let's think about Medicaid next. We have Medicaid in all 50 states. It varies by state, but we do know at Force, we've done some research, that 49 out of 50 states cover at least some genetic testing for patients. We know that BRCA testing, BRCA genetic testing, is covered in 49 out of 50 states. For Lynch syndrome, which is actually more common than BRCA mutations, but not associated with breast cancer for the most part, only about 40 out of 50 states cover that. And so that's something we're working on. Coverage of the downstream services, such as increased screening with breast MRIs or risk-reducing surgeries, can vary from state to state, but given the population that Medicaid serves, we know that most of these services, at least the essential services, are covered if the state covers the genetic testing. Unfortunately, it's a bit challenging to find because each state has its own program. So we advise that if you work in a specific state, you connect with your state Medicaid program to get more information on what they cover, just to have a solid foundation for referral of patients and what services they might qualify for. Medicare is a bit of a different beast because of the population that it serves. As we know, the majority of people on Medicare are age 65 and older. And the Medicare program, when it was first established in the 1960s, was not focused on prevention. So unfortunately, the way the program was set up, Medicare is actually statutorily prohibited from covering genetic testing unless a person already has cancer. And you might think, well, that defeats the purpose, but in fact, it doesn't, because utilization of those test results can help guide cancer treatment as well as additional downstream care. However, in our mind, this is problematic because we want to prevent cancers or at least catch them earlier, and knowledge of a genetic mutation can be very, very helpful in doing that. If a person comes into the Medicare system already knowing that they have a mutation, or they're able to pay out of pocket for a test and learn that they have a mutation, access to the increased screening and downstream care can vary. And while it shouldn't specifically vary under the Medicare program, we do see that the policies are not implemented consistently across the US. So for instance, in the Northwest, we see that individuals who are seeking risk-reducing surgeries, such as a hysterectomy or salpingo-oophorectomy to remove their ovaries and fallopian tubes, they have limited access. They get denied very frequently, whereas in other parts of the country, patients are not struggling with access to those services. So FORCE is actually working with members of Congress to spearhead legislation that would remedy this situation. This is the bill number House Resolution 1526 and Senate Bill 765. This legislation would allow Medicare to cover genetic testing for people who don't have cancer, but who meet the guidelines for testing, whether it be somebody else in their family has a mutation, or they just have the appropriate family history that would qualify them for testing under national guidelines. If those individuals were to test positive, it would ensure that they have access to guideline-recommended care, such as increased breast cancer screening, risk-reducing surgeries, based on national guidelines from reputable organizations such as the National Comprehensive Cancer Network, the American College of Radiology, and others. So this is something that we hope you will support by reaching out to your members of Congress and explaining to them how important this is. I've mentioned a few times that the costs of genetic testing have plummeted, and it's really quite accessible these days for individuals who maybe don't have insurance coverage, or who are struggling to get coverage, or maybe are uninsured. So we've gone from tests that were in excess of $4,000 about 10 years ago to anywhere from $0 to $300 for comprehensive medical grade genetic testing these days. So this is really quite accessible for the average American. And if an individual is uninsured or underinsured, they will often qualify for services, for these testing services at no cost through the financial assistance programs at most labs. FORCE is doing a lot to facilitate increased access to these services. So if an individual does test positive, where we struggle a lot of times is not just getting them access to the testing, the genetic testing, but also the downstream care. Even people with health insurance sometimes incur large out-of-pocket costs for things such as breast MRIs. And the rationale is that those services, because they go beyond what the U.S. Preventive Services Task Force requires under the ACA, insurers can apply the cost of those screening and preventive care services to an individual's deductible. So if you have a $5,000 deductible, you may end up paying a significant amount, $1,200, $1,800, for a breast MRI, for instance. And that can be a tough pill to swallow for many people. So we're working very hard to ensure that our high-risk community can afford the services that they need without financial barriers. This is a list of federal pieces of legislation that we are currently supporting that would benefit our community. One, the Access to Genetic Counselor Services Act would make genetic counselors approved providers under the Medicare program, because currently they are not recognized as independent providers under Medicare. The other legislation here, PSA screening for him, would eliminate the cost of prostate cancer screenings for anybody who's deemed to be high risk, and that includes Black men, as well as those with family history or a genetic predisposition to the disease. So that cost barrier would be gone. It would be free for them to get this screening. And we hope that that would increase uptake of these important screenings. Similarly, the Find It Early Act and the Access to Breast Cancer Diagnosis Act strive to eliminate the cost of high-risk breast screenings or diagnostic breast screenings. So if an individual has a genetic predisposition to breast cancer, they would be able to get their annual breast MRI with no out-of-pocket cost if any of these pieces of legislation were passed. Also, if an individual has a suspicious mammogram and they need additional testing, the goal of the Access to Breast Cancer Diagnosis Act would strive to eliminate that cost so that nobody is faced with putting food on the table versus paying to have additional testing to determine if they have breast cancer. So we think these are very important legislative efforts at the federal level, but we're also looking to find solutions at the state level as well, because sometimes it's challenging to push pieces of legislation through federally. So in the past year or two, Force has gotten very engaged with partner organizations and state legislative efforts. And just this year, Delaware, Maryland, and Nebraska passed legislation that eliminates the cost for high-risk breast screenings or supplemental and diagnostic breast screenings. So that's super important. Most of these laws do apply only to private insurance or commercial or employer group plans, not necessarily Medicaid and definitely not Medicare, but it's a step in the right direction. Pennsylvania passed a law that ensures coverage of BRCA testing, even though that's already covered under the ACA. It just solidified that coverage, as well as some high-risk breast screening. And then in Texas, we were successful in passing legislation that would cover fertility preservation services for people who are diagnosed with cancer or have to remove their ovaries due to high risk of cancer. All these pieces of legislation, at least at the federal level, are available in our Advocacy Action Center at this web address. And we update that information regularly. So we encourage you to reach out to your lawmakers. We have pre-written emails that you can customize to your senators and congressperson to let them know why these pieces of legislation are important and why access is so crucial for members of our population to ensure equitable access to care. I wanted to touch just a moment on genetic privacy and protections, because that is always a question. People ask us, can I be denied health insurance if I test positive for a mutation? What are the potential repercussions of me having genetic testing? So there are a couple of things that do protect, or a couple of laws that do protect people who undergo genetic testing. Of course, we have the Affordable Care Act, and one of the key components of that is that it eliminated the use of pre-existing conditions as a barrier to coverage. So whether somebody has manifest disease such as cancer or heart disease or diabetes, or if they're genetically predisposed, that cannot be used against them. Everyone is guaranteed health insurance under the Affordable Care Act. So this is so important. HIPAA also provides additional protections. So that's an additional component. But more importantly, the Genetic Information Non-Discrimination Act is a piece of a federal law that prohibits health insurers and employers from discriminating against people based on their genetic information or status. So if someone has genetic testing or a family history of disease, employers and health insurers are not allowed to use that against them in any way. And here we've defined how genetic information is defined. So it only applies to individuals, though, who don't have what's called manifest disease. So if somebody's already diagnosed with cancer, they could be denied certain types of insurance, but not under the Affordable Care Act. But before the Affordable Care Act, this came into play for people who were just predisposed to disease. It's very important to know that this does not apply to life, long-term care, or disability insurance. So basically, if somebody does undergo genetic testing and learns that they have a mutation, unfortunately, in most of the US, life insurers, disability, and long-term care insurers can use that information to adjust rates or to deny a policy. However, some states are going above and beyond and passing laws that add additional protections. Texas recently considered one, it didn't pass, but Florida and Tennessee have comparable strong laws that prohibit utilization of genetic information by life insurers, disability, and long-term care insurers. Other states, some other states have some protections, but they're not as strong. So it's important to look at where somebody lives to determine whether or not the information could be used in some way. That said, we find that most people are able to get an insurance policy. Sometimes they will have to pay slightly higher rates, but in most cases, these types of insurance, disability, life, and long-term care are available, even if somebody has genetic testing and has a mutation. So I've thrown a lot at you there, but I hope this was informative. Here's my contact information should you have additional questions, and I'll be sticking around for the Q&A so that I'm happy to answer any additional thoughts or concerns that you might have. Elaine, I'll pass it back to you.
Thank you, Lisa. That was an excellent presentation and lots of great information. And next, I would like to introduce our last speaker. Lisa, if you could stop sharing your screen and then Perry can share hers. Thank you. Our last speaker today is Dr. Perry Welch. She is also from Force, Facing Our Risk Empowered. And she's going to give us some more information about genetics and Force support services. Thank you, Perry, for joining us today.
Yeah, welcome. You're welcome. And it's always a pleasure to speak on a topic that's near and dear to my heart. I have a PhD in molecular genetics, and my postdoctoral project was almost 30 years ago now to clone BRCA1. So we'll speak a little bit more as a scientist. So again, I'm Vice President of Education now at Force after a long time in hereditary cancer research. So one of the questions people often have is what percentage of the population have an inherited mutation? So I like to use this image to emphasize that cancer is common. Currently in the United States, there are over 17 million people who have been diagnosed with cancer. Breast cancer is the most common cancer diagnosed in women. Prostate cancer is the most common cancer diagnosed in men. There's also a lot of colorectal cancer in the United States, and this thing's bugging me. And about almost 2 million people each year will be newly diagnosed with cancer. However, as Angela said, most of these cancers are what we call sporadic cancers. They're not due to an inherited mutation. However, about 10% of all cancers, and again, this varies by cancer type, are due to an inherited mutation. So what I've learned over the years is, even though we're emphasizing breast cancer here, we shouldn't speak about just inherited breast cancer by itself, because we know that, BRCA1 and 2, the heavy hitters, the big players in this field, about 1 in 400 Americans have a mutation in BRCA1 or 2. And as was mentioned earlier, it's much more common in various populations. So in the Ashkenazi Jewish population, about 1 in 40 people will have a BRCA1 or 2 mutation. But there's a lot of other mutations that increase breast cancer risk. And this list continues to grow. Importantly, what we now know is that mutations in BRCA1 and BRCA2 don't only increase risk of breast cancer, but ovarian cancer, prostate cancer in men, pancreatic cancer, and other cancers. And this is very simple. BRCA1 and BRCA2, which is often referred to as hereditary breast and ovarian cancer, is very similar to hereditary colon cancer or Lynch syndrome. About 1 in 300 Americans will have a mutation in one of the 5 Lynch syndrome genes. And not only are people with Lynch syndrome increased risk of colon cancer, also ovarian cancer, endometrial cancer, and a number of other cancers. And also, again, like breast cancer, there are other inherited mutations that increase colorectal cancer risk. And we often get asked as an organization, what percentage of all breast cancer that happens in a year is due to an inherited mutation? So, 250,000 cases of breast cancer are diagnosed each year. 12 to 14% of these are due to an inherited mutation. So almost 36,000 cases of breast cancer are due to an inherited mutation every year. And when you look at different cancer types, you can see what really jumps out here is that almost a quarter of all ovarian cancers are due to an inherited mutation. The lifetime risk of breast cancer in women with inherited mutations varies by gene. So you can see BRCA1 has up to about a 65% risk of lifetime risk of breast cancer. P10 also has a very high risk of breast cancer, whereas some of these other genes known to increase breast cancer risk have a slightly less lifetime risk of breast cancer. And I always like to show this slide because, originally all these families were ascertained on the number of females with breast cancer in a family. But now we know that a male with a BRCA2 or a BRCA1 mutation, although their lifetime risk is not as great as women with one of these mutations. You can see it's for BRCA2, they have about a 7%, men have about a 7% lifetime risk, whereas with no inherited mutation, they have very, very, very low risk of breast cancer. One of the efforts that FORCE is constantly trying to tackle is the fact that most people who have an inherited mutation that predisposes them to cancer don't know it. So only about 10% of the population that actually has a mutation know that they have a mutation. And 90% of the people, the millions of people that have a mutation that increases their cancer risk are unaware. So a big effort of ours is to help educate both providers, families, and individuals to learn about their hereditary cancer risk so that we can bring that number way down. One of the questions that was posed to us in preparing for this panel was that if someone has no descendants, should they have genetic testing? And the answer is no descendants, no genetic testing. No, you should have. There are people that should have genetic testing. And again, some of these red flags, Angela's already gone over. If someone has a cancer that's diagnosed at an earlier age than the average diagnosis, so breast or colon cancer under the age of 50, if a person has multiple primary cancers, so bilateral breast cancer, breast and ovarian cancer, even though they have no descendants, they should certainly be encouraged to have genetic testing. And again, certain pathologies, triple negative breast cancer, colon cancer that has a feature called microsatellite instability, rare cancers. So example, a male who's diagnosed with breast cancer, pancreatic or metastatic prostate cancer, and a strong family history of cancer. And this has been emphasized earlier by Angela. A family that would be expected by chance to have 2 or more generations in that family that have cancer. So you can kind of see the cancer kind of moving through the family. And of course, patterns of cancer associated with known cancer syndromes. So breast and ovarian cancer, or breast and pancreatic cancer in a given family. And this is the first family that Mary Clark King, who discovered that there was an inherited predisposition to cancer, and that first gene was BRCA1, located on chromosome 17. This family, in looking back, taught us a lot. So here's a patient, a person who developed ovarian cancer early at age 48, but had no children. Had this person had genetic testing, it would have informed all of her siblings, as well as their children and their children's children, that there potentially is a mutation in this branch of the family that predisposes to an increase in cancer. And again, these little B's mean this person has the mutation, has the variant. You can see here, a male in the first generation had prostate cancer, had the variant. Again, here's a person who lived to be, a male who lived to be 94, never developed cancer, but passed on the mutation to some of his children. Here's a pancreatic cancer at 66, very young breast cancers in this generation, 29, 39, 34. So this family told us a lot about not only breast cancer, but other cancers and ages of onset that are typical of high-risk families. Again, hereditary cancers tend to develop at an early age. So if you have a patient who's in her 30s that has been diagnosed with breast cancer, that's a sign. These patients have a higher risk for second or third cancer diagnoses. So once a mutation has been identified in the patient, they are at elevated risk for other cancers, such as pancreatic or ovarian cancer. And importantly, now that we have drugs that specifically target some of these mutant genes and their pathways, genetic test results can affect treatment options and prognosis. So knowing whether or not a patient has an inherited mutation could provide valuable insight into the treatment options that may be available that are more personalized to them. And again, people with mutations can pass their mutations on to their children. This is, I think, sometimes a hard concept for people to understand, because these, genes were cloned on breast cancer. And, men can't have breast cancer, and they can't pass a mutation on to their children. But we know that's absolutely not true. And I'd like to close with some of the support and other resources that Force works very hard to assemble, and a lot of this can be found on our website. But I'd like to highlight two programs. We have a program that's funded by the CDC called, we call it the X-ray program. It stands for Examining the Relevance of Articles for You. And what we cover in these articles are written in a very lay-friendly manner. And what we are doing here are summarizing kind of the latest research that's often getting covered in the popular press, or is controversial, or when new treatment options are approved by the FDA, we tend to cover those. And as I said, this program started through a CDC-funded grant, which originally only covered breast cancer in young women, but has expanded to cover breast cancer in young women, and now metastatic breast cancer. We've also have portals that X-ray reviews that are written for, pancreatic cancer patients, colorectal cancer patients, ovarian cancer patients. And we recently just opened up a portal specifically for hereditary cancer, people or families with hereditary cancer. Oops, I guess this is a double slide here. Yeah, so there's the hereditary cancer risk portal. So all these can be found on our X-ray landing page on our website. Another tool that we have as a resource that I think is very helpful for patients is we call it Search and Enroll tool. If anyone's ever been on clinicaltrials.gov, sometimes I, as a scientist, can't even understand what they're talking about. So what we do here is break down research studies with an emphasis on those studies recruiting patients with hereditary cancer mutation, and we write very lay summaries of these trials. And this is a searchable database. So, a patient is interested in joining a trial that might be looking at quality of life, they can search specifically for those studies. Again, hopefully that wasn't too much science. As everyone else who's on the panel expressed, feel free to reach out with any questions, and there's my contact information. And I'm happy to answer any questions.
Thank you, Perry. That was an excellent presentation. I'm going to invite Angela and Lisa back on screen with us. And again, thank all of you for those presentations, very informative. We are going to get to some questions. Please put your questions in the Q&A or in the chat box, and we'll be happy to answer those. And I know some of those were already answered in the Q&A box. So we do have about 15 minutes, and so we're going to get to as many questions as we can. So I would like to start off with one question, and I'm going to invite any of you to answer the question. And so with increasing availability of genetic testing, how can we bridge the gap in lack of resources for disparate populations?
Well, Lisa, that's your.
I thought Angela might be able to help that too. So I actually posted in the Q&A, we have some resources on our website for individuals who either are uninsured, underinsured, or their insurance is denying coverage. They can get access to genetic testing from anywhere from $0 to $300, depending on their circumstances. I think importantly, once those individuals have testing and get counseling, they need to be able to have access to the downstream care if they test positive. And so it's very important to know about the resources in your communities. So for instance, resources to help cover the cost of additional breast screenings or any other services that they might need should they test positive. And so we encourage you to connect them with financial navigators or nurse navigators who can help them access those services if they don't have a good provider who can help them with that, because it's not just about the testing, it's more about what happens after if you are identified as high risk.
And because every state is so different, I would encourage you to contact your genetic counselors. I gave you references about how you can find them. Contact local organizations. For instance, we have a program for young women or young people with breast cancer that does a lot to look at financial issues related to breast cancer specifically, but there are other organizations that can look at that for other cancers. So connect with those organizations. Advocate if you see that there are bills coming down the pike in your state that will promote and support better coverage for testing services, whether it's genetic or otherwise. Get out there and vote and advocate for those. That's how we can make a difference.
Great, thank you. We did have a question come in the Q&A. So how often is testing recommended? And I'm not sure, that might have been answered already, but additionally, this person had testing approximately 5 years ago with no mutations identified, however, have multiple relatives across 3 generations that have had breast cancer.
So in that case, genetic testing is expanding pretty much every 6 months. I think there's more genes that have been identified and added to the genetic testing panels. So there's a couple different approaches. If the patient's already had genetic testing, it's been 5 years, have her recontact the genetic place, the counselor or whomever she had genetic testing through, and see if there's additional testing that might be warranted depending on what was on the panel or whatever test she had. If other family members, given that other family members also have cancers, it might be beneficial to have some other family members also pursue genetic counseling and testing. Sometimes even in a strong family history of cancer, one person with cancer might actually have a sporadic one and somebody else in the family has an inherited one. So that would be a second approach that I would recommend. And for anybody that's had testing, especially more than 10 years ago, definitely recontact the genetic services where you got that testing and see what new testing is available.
Go ahead, Perry.
I heard a genetic counselor make a point. I thought, made a little mental note. It's a good point that, even if you've had genetic testing, say 5 years ago, just make a note on a calendar once a year. Reach out to your genetic counselor and say, hey, should I have testing again? What's changed? Is there anything new known about my mutation? Maybe they had a variant of uncertain significance, but that's been now reclassified as to what we would call a pathogenic or a real mutation, or maybe it's been reclassified to a benign mutation. So there's a lot of, things are constantly changing, new genes, reclassification of variants. So, it's a good idea to reach out to your genetic counselor, once every year, once every 2 years to see if anything has changed.
I was going to jump in and just give an example. I worked with a patient recently who very strong family history of breast cancer. Mother died in her 30s from breast cancer. She was diagnosed at 40. Her sister has metastatic breast cancer. Her aunt had breast cancer. And all testing in the past had not shown a mutation. Her cousin just had testing with the most recent panel, and they did find a mutation. It was a CHEK2 mutation that was recently reclassified from a variant of uncertain significance to a pathogenic mutation. And so now they have an explanation as to why the cancer is occurring in this family. And they can, have that additional testing for the other family members who previously tested negative. And now they know what to do as far as the guidelines for additional screening or prevention and what to test for the other family members. So I do think, and this individual had testing as recently as 3 years ago. So it does happen. These mutations do get reclassified, new things do get discovered. So with a family like that, it's always worthwhile to explore additional testing if they've previously tested negative.
And
I'm sorry, Lisa, I just wanted to ask a question because I know that you, talked about the cost being covered, but for these multiple tests, how does the cost, are they still covering?
Typically, with the insurance, they will specify that, and again, this is insurance, Medicaid and Medicare can be slightly different, but most of them do say that if you are testing for new genetic material, meaning looking for newer mutations, they will cover the additional testing. And we've heard, we haven't heard of any significant issues with people getting retested if they previously tested negative. So that is certainly something that typically is covered. And if an individual does feel and their provider believe that additional testing is indicated and the insurance company is pushing back, we're always happy to help. Force has sample appeal letters that can be used, or we have staff members who have expertise and volunteers who have expertise to help navigate that appeal process.
And your genetic counselors can write letters of medical necessity as well to help the insurance company understand, and sometimes even talk to the people making the decision so that they understand the value of doing additional testing.
That's where genetic counselors come in really valuable. I find that they are so helpful in justifying coverage for these types of tests. Sometimes other providers don't necessarily have the knowledge or expertise or time to deal with it, but genetic counselors are really experts at this.
Perry, I'm sorry, did you have a comment?
One of the comments that I was going to make is that, it's important for providers to, ask the question constantly, has your family situation changed? Are there new cancer diagnoses? A family that, has a lot of that, where there may be 1 or 2 breast cancers and now there's a pancreatic cancer, that's going to be, more indication that there may be something going on in that family. So constantly updating family cancer history, I think, is important because that's constantly changing.
Okay. I want to move on to another question. So are there suggestions for high-risk assessment at a community hospital system with outpatient imaging centers? Any kind of suggestions for them?
There are some centers that have integrated quick family history questionnaires into their screening service, and something that can be done very quickly by the patient, self-administered. So that might be something that you do to look for some of those red flags.
Okay. And then let's see, we have another question come in that said, we help individuals enroll in marketplace insurance. How can we help clients choose a plan that will provide coverage for genetic testing? Are there any resources or key information to look at in the summary of benefits?
So I'll take a stab at that. As I've shared, most health insurers do cover genetic testing. As Blue Cross, Cigna, United, Aetna, they all do. They're required to cover it if it's an insurance marketplace plan. Under the ACA, they at least have to cover BRCA testing, but most of them cover testing more broadly. You want to steer patients away from any short-term catastrophic type plans. They are not the type of plans that are going to provide the appropriate coverage for this. We do have some great resources. An organization called Triage Cancer does a phenomenal job, as well as the Patient Advocate Foundation, in providing guidance on good plans for people who are enrolling through the marketplace. But I would say that pretty much any mid to high, I guess, moderate to, I don't want to call it a Cadillac plan, but most of them will cover the testing. So you want to just look to see if it talks about coverage of cancer genetics, hereditary cancer assessment, that type of thing. Many of them do have policies on that. Unfortunately, those statements may not be visible until you actually subscribe to the plan. So talking to a customer service representative could be helpful in vetting that. But as I shared, triage, TRIAGE cancer, as well as the Patient Advocate Foundation are phenomenal resources for that.
Wonderful. Thank you so much. These have been excellent questions. We have just a couple of minutes, so I do want to give each of you just a minute or a few 30 seconds if there's any final thoughts you'd like to leave our audience with.
I would just like to say thank you for being here today, because when people like you care about improving access to genetic counseling and testing, everybody wins. So thank you. I know it's a Friday. You could be out doing something else in the middle of summer, but we really appreciate you being here.
And I'll jump in and just speak from a personal perspective. I happen to carry a BRCA1 genetic mutation. So this is both personal and professional for me. And a lot of times there's concern that a patient might not want to know this information, that it's a heavy burden. But I tend to look at it from a different perspective. It's a blessing. It's a blessing because it can empower the patient. It empowered me and my family to be proactive and to sort of end that cycle of early onset cancers. And to help catch them earlier. And now we have an explanation. So I think, talking culturally, everybody has their different priorities, different values, but, family is a value that everybody understands. And so viewing it through that family lens of this is an important thing for our family can be very helpful. So that's just my 2 cents, but thank you. And obviously, if there are any issues with the people you serve having access, please don't hesitate to reach out to us.
I think another resource that I didn't talk about that Force does an extremely excellent job at is we have a peer navigation program. So, if someone discovers they have a mutation in ATM, and they want just to talk to someone else who has the same mutation, we can match people seeking support by mutation, by location, by cancer type, by maybe issues that they're having about how do I talk to my family about this. So I think our peer navigation program is an excellent program, and it can help patients overcome some of those barriers, be it understanding, I have an ATM mutation, what's my cancer risk, or I come from a family, we never talk about our medical conditions. How can I begin that conversation? So,
And I'll just add that we have support groups also, and those groups can serve some populations that maybe historically we don't think about, like the LGBTQIA population, men, individuals who are high risk who haven't been diagnosed. So we really try to address the needs or provide support to people from all different walks of the community.
Thank you so much. This has been an excellent webinar. The presentations were so informative, and I know that our audience is going to walk away with a lot more knowledge and tools. So thank you so much. I appreciate you being here today. Thank you for joining us, everyone, and have a great day.